I have the pleasure to introduce the next speakers. Nicol van Dyk. He's physiotherapist and clinical researcher. He works for the Irish rugby football in Dublin. He has worked in several sporting environments and athletics, football, rugby. His doctoral thesis dealt with risk factor for hamstring injuries, and his presentation deals with muscle injury to the anterior thighs. Nicol, you have the stage. Thank you to be here with us today.
Thank you. Thank you, Nicola, and thanks, everybody. Can everybody hear me okay? Yep. It's great to be here. It's my first time in Bern. Overwhelmed. It's such a big day. And so thank you for sticking around to the end. I'm a little out of my comfort zone. So Mario asked me to speak about the anterior thigh. But I'm pleased to do it, and forget me not, because we kind of don't talk about the anterior thigh that often, I think. But we have heard quite a bit today, so I'm pleased about that. I have nothing to declare. I'm yet to find a drug company to sponsor my trip, so if you know of anybody, give me a shout. I'm open to that conversation. My main job is with the Irish Rugby Football Union as the medical research lead. So I do a little less clinical work these days and more work around our projects. I do hold some academic positions. I do a bit of editing for the British Journal of Sports Medicine and some consulting recently in the sport and health technology world. So really pleased with all these different opportunities. I'm from Cape Town, if you haven't guessed that yet by my very obvious South African accent. And it's a great place to be, and if you've never been, I really encourage you. And then I had the opportunity to join the Aspetar Orthopedic and Sports Medicine Hospital in Doha, where I spent 7 years, did my PhD project, and learned a lot from folks like Rod and many others. So really great to have had that opportunity. If you're not aware of it, the Aspetar Sports Medicine Journal is freely available online, and it's an incredible resource. There's so much good stuff in there. So go and have a look. This is the view some mornings when it's not raining in Ireland. On the Sport Island campus where our high-performance facility is built. We're very fortunate. We're a bit soft, so we need to train indoors. No, I'm just kidding. So we have a really great facility for the staff and the players. And our system is doing well. Ireland has a really healthy rugby system. Our development pathways, our under-20s in the top right-hand corner there, has been very successful. Both our women's and men's sevens team have qualified for the Olympics in Paris, so I'm really looking forward to that. And our women's team, although they've dropped down a tier, have really done well in the recent months. So we're building that pathway as well. But our main product, our flagship team, is our men's national team. And you heard from Machi, our lead physio, just before the break. We had a really good year. I still want to say that. We started off number 1. We ranked number 1 for most of the year. We won the Six Nations. That's the premiership rugby competition in Europe. And we beat everybody. We won the Grand Slam. And we really believed that the World Cup would be the year for us. So we had an incredible atmosphere in the stadium during the group. We even had some supporters over here in Switzerland. But it didn't turn out that way. So we lost in the quarterfinal, and that's sports. That's the environment that most of us are in. And I would argue, even if you're dealing with athletes that's not elite, it's about participation, and the margins are small, and we want to keep our athletes healthy and able to perform. The loyalties are somewhat divided in our house, as you can imagine, although we did support Ireland. So not too sad, I have to admit, when South Africa won the World Cup. So congratulations to them again. But it's not always rosy, right? So the South African cricket team would know what it's like to lose in knockout matches. This is the Cricket World Cup. Australia won for the 6th time, and they beat South Africa for the 4th time in the semi-final. And I can tell you this. There's only one thing worse than losing, and that's losing to Australia. And Rod, I mean that from the bottom of my heart. Okay, so this is what we'll cover today, a bit of a tour de force around the anterior thigh. We'll look at some epidemiology. We'll cover some risk factors and mechanism of injury. We've heard some of that already. Quick tour through our assessment and rehab, and then a few notes just on prevention and how we look at it at the IRFU. This was tweeted recently, so for those of you, before we do the epidemiology, this is a bit of etymology. So the real way to say quadriceps is quadricipites, but that sounds a little funky to me. I think we'll stick with quadriceps. And if we think anterior thigh, I acknowledge that there's loads of other things going on, all our groin and adductor muscles, the iliopsoas, but we're really only going to talk about the quadriceps. So the rectus femoris that's resected there and the 3 vasti muscles. And as Rod said, all schematics are wrong about anatomy, but that is just to say this is what we'll cover. Also, there's different ways that muscles get injured, right? So we're really talking about strain injuries. Contusions is a bit of a factor, especially in the anterior thigh. I'm not going to talk too much about that, but we really are thinking about strain injuries when we're presenting all of this data and research. So let's think about the incidence and how often these injuries happen. This is a risk matrix from a while ago now, and I think most of us have seen this type of graph in the literature now. So on severity on the y-axis and incidence, so the number of injuries per 1,000-hour exposure on the x-axis. And the only thing really is that muscle injuries happen quite often, but they don't keep us out that long. They're not like ACL injuries that ruins your season. So it's something we often have to deal with. Hamstrings still probably, definitely a more common injury, but quadriceps, calf, and groin injuries are in there too, right? I still like this. When Barcelona and the Innovation Hub was running at full pace, it was a really great, handy muscle injury guide. And this is how quadriceps feels to me, and Rod presented that too, right? They're kind of in the middle of the pack. We have our hamstrings, we have our adductors or groin, and then we have the quadriceps. And we do a lot on hamstrings and adductors, but really not that much on the other stuff. And if you think about how a season looks, it's probably a little bit like this. You have those early season hammy calf injuries, and then the quads are kind of there, not, but they happen, right? We have to deal with them. That's from 2011. In 2022 or 21, they published an update on that, and so it hasn't really changed. We know that all injuries have gone down, muscle injuries not so, and hamstrings probably the biggest contributor to why muscle injuries are staying the same. But it's not terrible, right? And I think we have to remind ourselves that injuries are actually rare events. Our athletes sprint and compete a lot. And they don't, every time they sprint, they don't have a hamstring injury. So how do we protect our athletes by knowing this? And I just wanted to mention that's predominantly male data. So in females, we're kind of seeing the same thing. This is from Ireland and Dan Horan at our football federation. And you can see that the thigh injuries are the most common, about 20%, and both hamstrings and quadriceps contributing mainly to that. So we know they happen often. They're kind of in the middle of the pack, and we do need to deal with them. So what do we know about risk factors for injury? And can we identify different intrinsic and extrinsic factors and mechanism of injury? Now, we know that sport is complex and that injuries happen for a variety of reasons. And Natalia will speak about that after me. But I want to remind us that it is a complex environment, and it's really hard to sometimes predict the outcome of what will happen. Did you guys catch that, right? There's sometimes a bit of a risk for the staff as well. So if you're in the bottom corner there, the physio is doing his best. That doesn't end well. So I'm not going to try and explain that risk, but Fekitoa still scores the try, by the way. So the best paper I know that's looked at this is just last year from Latrobe, Tanya Pizzari, and her group. And surprise, surprise, previous injury. We know that. So if you've had a previous injury, and Monica explained that really well this morning, you need to pay attention to those folks. A recent hamstring injury, that's interesting, isn't it? So again, this reminder that these things don't happen in isolation. And the dominant kicking leg, those are kind of the intrinsic risk factors that really stood out. I think that the dominant kicking leg might really hold to the injury mechanism as well. Then competitive match play, that's not a surprise to me either, right? So a higher intensity game brings up the risk. Pre-season, so we know that we often see an injury spike in pre-season. What was interesting is they had no association with age, weight, and flexibility. So like Rod pointed out, there's not a lot of data here, but that is what we have. Flexibility is quite interesting. I always think of flexibility when I think of quads. And I did want to, the forget-me-nots here would be previous calf injury and previous adductor injury also peaks in there. A lumbar stressy, so that's interesting. They also looked at stuff like the weather, playing surface, recovery. All those factors, there were some really mild, not very limited evidence around that, but I think it's important that we also pay attention to those factors. So yes, we have our big stuff we need to look at and always be mindful of, and think about these other contributors to that. From Aspetar, they did a really nice piece looking at about 105 players, was it, Rod? And so Rod already mentioned this, but just to re-emphasize, it's kicking was the main injury mechanism, sprinting about a third. That's a little more than in other studies. And the free tendon is the most commonly injured, right? Sorry, the myotendinous junction is the most commonly injured, but the free tendon were all related to kicking and were really serious. So all the serious injuries to the free tendon were from kicking. This is confirmed in another study just published recently, kicking the main injury. They added change of direction in their piece, so sprinting and change in direction, but that's really how these injuries seems to happen. Okay, so what do we do with that? Well, for me, if we go back to, this is a paper from Anthony Shackey in 1999, not much, I know they've done some updated work since then, but just to highlight where the pelvis shifts, and it's not big, right? That's a subtle change in range at foot strike and toe off. So we know that there's this proximal to distal sequencing when we run. What happens with kicking? So I think this video is really highlighted nicely, because you see how the player moves into, when he plants his foot, coming through that trunk extension, anterior tilt to posterior tilt, flexion, hip flexion, knee extension. And so that sequencing that happens there. Now, I don't know how much we can influence that, right? So we've heard from JB that the mechanics of sprinting, surely, there's something there, and maybe we can influence this. But I think it's core to what we do in our rehab. So are we paying to trunk rotation? Are we paying to lumbar-pelvic dissociation? Can we help them with the control and then build that back into what they need for the sport? It's not quite the same for women. The nice thing, so this is Molly Boyne, she plays rugby for Ireland, and she did this in her free time. She's a physio as well. And one of the interesting things from this paper we did was that the experienced player used the tension arc to better effect than the novice player. And that makes sense, right? You learn how to create power through your movements. Women has less plantar flexion. They try to use, or they do use more trunk rotation and flexion to build into that kicking mechanism. So I think it's important just to remember that there are these differences. How that might change over time will be interesting, but certainly something to appreciate at the moment when you're dealing with different athletes. Okay, so if we move on to the assessment piece. Now, what predicts a good outcome? So before we get into the content, and I know that's always the thing we want to focus on, I think it's a really good reminder, and this is from the brilliant mind of Phil Glasgow, who was here last year, but we need to have trust. You need to build a relationship with your athletes. It's absolutely vital that is the foundation on which this is built. And then we want to have commitment to the process. We want everybody to understand what's going to happen, and then focused on the same goals. Where do we want to go? And hold each other accountable to the roles and responsibilities we assign. And then it's about our exercise selection or our therapeutic technique. So this is what Phil would call the therapeutic alliance, or drives towards that. And I absolutely think this is where it needs to go. It's really hard if you only have 20 minutes, I'm not going to lie. So I do think the way, if we can and should make an argument for why that's really important. And part of that is moving from diagnosing to dialogue. So moving into that story of the athlete, understanding what they're saying. And it's the old adage, right? If you listen to your patient long enough, they'll tell you what's wrong. And if you listen to them a little bit longer, they'll tell you what to do. So I really want to emphasize that. Carlos did a great job this morning with imaging. The only things I want to mention, again, he already mentioned the intramuscular strain. So that's on the right there. And this is from one of the first papers published on this. And on the right, it's a Laval lesion. So Carlos, you can speak more clearly on that. But when you have a contusion, and we had this in our Emerging Island tour, and it looked okay. We got them in the gym, they were okay. We pushed a little bit back on the field, and disaster. Just everything blew up. And luckily, we were thinking what could potentially be here. And that's that degloving injury with lots of issues around that, right? So just be aware when those contusion injuries don't work out the way you think, just be mindful that it could be something like that. But our friends in Denmark has done a really good job at synthesizing the evidence around both diagnosis, prevention, and treatment of these injuries. So I'm going to lean on this paper a little bit. And for our rec fem or our quads injuries, we really want to focus on palpation. We want to do strength testing. So at 0 and 90 degrees, supine or seated, there's probably a range there you can look through, and then the modified Thomas test. So I'm sure you're all very familiar with that. It's really, the test is really simple to execute, so you have to do it right. But then it's really observing about what you see. Is there a hip flexion contracture? Is there an extending knee? What are the potential cues that helps you understand where you can pay attention? Now, this is when Rod still had lots of hair and he was way younger, probably in his early, I don't know, 40s. So, and Phil Jacobson at Aspetar, and they figured out, well, we want to measure stuff because we need to know if what we're doing is working, and we need to know how to progress. So this was one of the tests. We did a bunch of hammies there. On the bottom there, you could see the correlations are really strong. This was a real makeshift. We fixed the dynamometer to the plinth, but it worked really well. So if we're executing that test the same way every time, then it was very reliable. We have more fancy tools now, and I encourage you to explore how you can use these new devices that's at our disposal in an effective way. Because it really is important to understand that these measurements can inform our practice and help us to make better decisions around how we provide rehab and how we progress our rehabilitation. Because it's not what you don't know that gets you into trouble, it's what you're absolutely convinced of that just isn't true. And that has been so true. So Rod introduced me to this paper. It's in horse racing, and they went to bookies and said, okay, on the y-axis, we'll put your accuracy, and on the x-axis, we'll put the confidence. And now we're going to give you items of information. So let's see how accurate you are with that new information. And it doesn't really change, but your confidence sure does. So more data isn't always better, right? More exercise isn't always the answer. It's about understanding how we interpret and use that data in our clinical reasoning. So again, I think in your clinic, think about how you could measure range of motion, strength. I've added some compression tests here because that's probably what I would add in there too, not just the tension tests, although they work a little better for quads, in different positions potentially. But make sure you're executing the test the same way every time, and make sure you're getting accurate data when you do, because that will really help to inform your process. So as Rod kind of alluded to this morning as well, I don't think our assessment of any muscle injury has really changed that much. Look, listen, and feel. If you have the opportunity to observe the mechanism of injury, that's really fortunate, but also functional movement and just how the patient presents to you is really important. Make sure we pay attention to what their story is and how they're experiencing this, and then palpation, length, and strength, right? That's it. It's as simple as that. Now, if we think about how that feeds into rehab, I love this quote. I know he's not there anymore, but when asked about all the new innovations around the club and all the technology they're introducing, he's like, look, man, 30 years ago it took 20 days, still takes 20 days. And that's kind of true, right? There's some biological or basic healing principles that we will never change. But what we do in that period and how we treat them, I think, has changed dramatically. And I think we're a lot better now at providing adequate, optimal rehabilitation that not only drives down injury risk, but really improves performance. Now, when you're having the rehab conversation, you can ask Machi, it's not always the same conversation we're having. So the coach really has a performance focus. They're thinking about what they need to do on Saturday to win the game, win the league, win the World Cup. The player has a goal focus. They want to get back out there, and I don't blame them. I get it. I'm the same, right? So as soon as you have an injury, how quickly can I get fixed? I want to go play. And then the physio has an outcome focus. We want to make sure you're healing appropriately and that we are not putting you in a position where you will get injured again. Now, getting them to pay attention to you around that conversation is the hard part, and we're probably still the only long-term health advocates for players in our teams or in this system. So it's really important to acknowledge that role too. That's not to say we shouldn't have a performance mindset, though. Absolutely, right? That's the game. But we can shift our narrative to make sure we're providing the information we're sharing in the appropriate way. So I just thought about some questions that could help us when you're planning your rehab, right? So when you're trying to design a program, think about what's happening at a tissue level. We have some great new information today around that. What outcomes are you trying to achieve with your exercise? So what are you looking to get to? Is the adaptation associated with that exercise what you're trying to achieve? And is the stimulus you're providing going to drive that adaptation? Oops. Yep, sorry. And then, are you trying to do one of three things? Are you reducing symptoms? Are you trying to change the tissue capacity? Or are you trying to improve movement capability? So are you trying to get the fascicles longer? That's important. or have you now moved to a coordinated movement-based force velocity curve or rate of force development-based exercise? So when we think about it from this principle, rehab is training in the presence of injury. I absolutely love that philosophy because it has changed the way I approach it. And I was fortunate, like Rod said, we had loads of time with our athletes. A hamstring session would often last more than an hour for us because if you see your athlete every day, some days you don't do anything, right? Because if you've had a really good training day the day before, they're smashed. And then the tests we do, the measurements we do, would show us that. Their response would show us that. So the Rod-Whiteley pain questionnaire, are you better, worse, the same, is really handy, right? And then all this other data will help you drive those decisions. So when we think about performance rehab progression, and we think about the early stage, we are moving from that more structural focus to the more neural focus, to Boris's point earlier as well. And initially, we're really training movement skills. You're training to train. It's limited and constrained. You're looking for perfect form. You want them to do the exercises well. You want them to execute the number of repetitions and sets. You want consistency. So there's some examples that I've stolen from James Moore without his permission. So closed kinetic chain, open kinetic chain, hip, knee, or ankle focus. Now remember, when we change the focus of the exercise, we're changing the exercise. And this is back to some of the skill acquisition literature that this is based on too, because that focus point change will change your attention, will change the drive. So really, when you're cueing your athletes, really pay attention to the language you're using, how we're shaping those exercises. When we get to the mid-stage of the rehab, we're really now trying to improve our technical skills. So we're training to create. There's a bit more choice. Although not a plethora of choice. So you don't need 60 exercises, you need 5 or 4 really good ones. At least that's been my experience. There's a bit more task-based constraints, but the movement solutions can be a bit more messy. And then when we get to so those are examples again. So the reverse Nordic, it's just hard to load it, isn't it? We'll talk about that in a second. Step up and downs, and then starting to move into running-based patterns, A-drills, skips, really encouraging them, maybe some tension arcs exercises or with the bands, creating some resistance. So you're moving away from that closed, consistent exercise space. And then in the late stage, now we're talking about performance skills. We're being sport-specific, we're being open to creativity, we're introducing speed, we're introducing technique, and we now move towards spatial and temporal compliance. We're going to do this for 10 minutes. You're going to do this in this space, in the gym, out on the field, but we'll do 5 by 5 or whatever it is. So I think that is a really good way to approach your rehabilitation on, as Machi said, on that return to sport continuum. That's where we want to sit. We ultimately have to end up in the performance space, and we have to get some level of exposure there. Now, for our philosophy has been we chase intensity and then we build volume. We want to get you there, and then we want to sleep high and live low. That's really what we're trying to achieve. And when we're doing rehab, we're pretty much doing the same thing we do all the time. So our pillars of quadricep management, and I put management there on purpose, it doesn't change whether you're injured or not. But certainly when you're injured, we're focusing on the healing and the therapeutic element of it rather than the performance, and that just naturally shifts over again. So we want those regular exposures to high-speed running. We want that proximal distal sequencing, trunk and lumbar pelvic control, neuromuscular control, force velocity capability, and then that eccentric strength. Yeah, does that make sense? That's not very different to hamstrings. That's not very different to calves for me. I think that's a really good way to approach a lot of your rehabilitation. Right, so the last bit, we'll do just a little bit on prevention. And I've got the wrong subtitles there, but we'll focus on this paper again. So this is Adam Virgil's infographic of that paper. Lots of evidence on hammies, tons, as you know. Mainly based around the 11 plus, and then the Nordics. So for groins, it's the same. So lots of evidence around groin rehabilitation. Adding the Copenhagen groin exercise to the 11 plus seemed to work really well. That red line, this is a forest plot. So everything on the right side of that red line doesn't work, and to the left works. If the confidence interval crosses the red line, it's kind of a bust. So we're leaning more left, right, which is good. Same here, or we're getting a bit closer. And then Nothing for quads, not really. Some non-significant effects were found with the 11 plus, with a 27% lower injury risk, but not statistically significant. I'm still paying attention to that, but we have a lot of work to do in this space. So if we think about what those papers are telling us, yes, hamstrings and quads and groins we have some injuries for. We have nothing for calves. Really, it's a really open space. So if you're interested in doing your PhD, that would be a good one to pick. I still like this paper from Jordan back in the day. I think it is from 2012 as well, where he just made some really nice observations. If you're going to pick 4 exercises to use, these are pretty good. Like, I really like them, right? We spoke a little earlier, Rod and I, about how do you load a reverse Nordic? Because I don't know if you've done it. It's really hard, right? So you add weight. That's 2 legs just doesn't work. So they're experimenting with doing it with 1 leg, and we can maybe chat about that. Step-ups, using bands and creating force, sled pushes maybe, but that's going to be focused more on the calves. But certainly using the TheraBands, the same way we would do for our adductors and our groin, and then the tension arc type exercises. We don't have an injury prevention program at the IRFU. We have a robustness program. And we define robustness as the capacity to consistently engage in training and games with maximal effort. Now, if your injury prevention works, that's the result. But that's it. That's the game. That's what we're trying to achieve. And our players do their prevention, both individual and as a group, but with this focus, with a performance mindset. And it has been a game changer for us. Machi, maybe I could just mention that, because Machi is pretty humble, but we had 4 injuries in the entire World Cup. We had no concussions. It was a pretty phenomenal medical department performance. So that didn't win us the World Cup, but that's really important for us, right? We know that those performance goals, those process goals, are sometimes different than the outcome, but we want to do everything we can. So this is a great paper from Phil Glasgow, and this is, I think, a key element, right? So when you have a very narrow performance zone, any constraint you place on that might shift that and lead to either injury or underperformance. What we're trying to do with that program is increase that performance zone. So when I replace these constraints on you, you're not that affected. You can take what we're throwing at you. You're prepared for the game. I think injuries happen more often because the organism, the player, isn't ready for what's going to happen. We've seen this in some of our injury mechanism video analyses where the ball just hits something and it's just in a different spot. I think JB's example of the player tugging on the shirt, that happens all the time. So why that one? Like, why wasn't he prepared for that one? And those are interesting questions, I think, to answer. But what we can do, what we definitely can do, is increase their robustness and their performance zone. So we create this balanced system in the end. What I will say, and this is true for all of us all the time, and we'll keep hammering this home, context is key. So you have to appreciate the environment you're in, the task you're trying to perform. If you're not sure about it, try and get some help. Right? Get somebody that understands that environment better. Speak to the coach or the player, whoever you need to, because the solution might be a lot simpler than you think, but if you don't appreciate the context, you're just never going to get there. Right? So the forget-me-nots for me, we need to move from diagnosis to dialogue. Really listen to your patients, to your players. Do the basics well. They haven't changed. Trust your clinical intuition. That's okay, but back it up with data, because if you don't know, you don't know. And then for us, robustness is the program. Thank you for your attention.
Thank you very much for your interesting presentation. Are there questions from the audience?
Okay, I knew, okay, I've got a surprise. Let's go. It's quiz time. So, because, you guys know this stuff, right? So, okay, so this is Anna van der Made. Dr. Anna van der Made is an orthopedic surgeon from the Netherlands. I also didn't ask his permission. I'm just using his stuff. So, you have to tell me what this injury is. So, put your hand up if you know. Okay, I'll make it a little easier. Rod already has his hand up. Anybody else? Now you can just use deduction to figure that out, right? Okay, Rod. Okay, can you be a little more specific? Nice. you want to say that over the microphone? Did everybody hear him? Proximal biceps femoris tear. Done. Here you go, Rod. Well done. Okay. Next one. It's pretty obvious. There's one little thing I want you to say. I'll ask it if you don't. It's the thing I've presented on. Hand up. Yeah? Yes? Yes. Tendon intact or not? Tendon intact or not? Not? Ooh. Yeah. Okay, but you still get a ball. Sorry. Okay. Quickly. This is obvious now, guys. Let's go. Anybody? Any takers?
Not yet.
Yes. Well done. It's a pretty good throw. Tendon rupture, right? So it just completes the giveaway, right? Nice and easy. Ooh, just to mix it up. Let's go. It's the left leg. I'll point it out. Any takers? Don't say hamstring, please. Yeah. This is a nice one, actually. Who said that? Oh, stop. Okay, you're out. You're not getting 2 balls. Yeah. The only thing to add to that is that it's a distal rupture, right? So, okay, this is going to be random. Whoever catches this one. No? Nobody wants my Irish souvenirs. Okay, last one. I love this picture. Tricky. Hands up. Rectus femoris. So if I draw that out, because this patient has such big vastus medialis, kind of hides it, right? It's unbelievable. I wish I looked like that. And then it's completely retracted. This is actually a full thickness tear of the musculotendinous junction. So yes, sir. Where are you now? Yes. Well done. Yeah. Boom. Thanks for playing, guys.
So do you have questions? No? I have a question. You know, we talk a lot about the brain and the impact on the brain of the injuries. That will be the next topic for the next symposium next year. And what do you think of its implication when you had an injury?
Well, it's absolutely. So, well, let's distinguish. You know, are we talking about just pure neuromuscular function? So, neuromuscular control. I know that's really wide. We just kind of use that term, right, for a bunch of stuff. But are we talking about anxiety or more psychological?
No. I was more thinking about what about adding cognitive tasks to the rehab, maybe because.
Well, do you? Who does that? Hands up if you do a bit of cognitive stimulation challenge. Yeah. We, like at Aspetar, especially with our hamstring program, the end part of our rehab was all on field, and we had trainers who basically created training in match situations and constrained it until you went out to really simulating that whole process. So when we think about, let's say, proximal to distal sequencing, we can influence that, but eventually they have to go back out to the field and catch the ball and pass it and kick it. So yeah, absolutely. Just on the neuromuscular side, so we know, especially in hamstrings, it's definitely a factor after injury, right? But less so before. So we ran a big risk factor trial on that, and that was a bust for us. Maybe it's the way we did it. But it's not to say I wouldn't add it into my program. So that's a good suggestion.
Thank you.
Okay, Nicole, thank you once again for your presentation.